A very good evening to all of you. Hetero here from the Medical Services Department of Hetero Healthcare. On the behalf of Hetero Healthcare, I would like to welcome you all to this very thoughtful and insightful session on Midodrine, the right approach. Hetero Healthcare is an innovative pharmaceutical company for more than 3 decades, which caters to around 14 plus therapeutic groups aiming to improve patients' quality of life. Hetero is amongst the world's largest manufacturers of APIs and has been majorly involved in tackling the national emergencies over the years. Only due to 25 plus state-of-art ensured the seamless supply of medicines. As a solution provider, our prime focus is to the current needs of doctors and patients to uplift human life. Liver diseases are gradually becoming the public health priority in India. It is found that around 1 in every is affected by liver diseases. Liver cirrhosis has accounted for almost 2.1% of all the deaths in India. Patients with cirrhosis are at increased risk of serious complications such as portal hypertension, ascites, refractory ascites, hepatorenal syndrome, etc., which decreases the life individual. Dietary sodium restriction and diet cornerstone of the management of such complications. When refractory to therapy, large volume paracentesis is the standard of care. In selected cirrhotic patients with RA and HRS, TIPS is the treatment modality. Despite novel therapeutic regimens, liver transplant becomes the prime therapeutic management option, which actually corrects the underlying consequences. It is therefore very crucial to diagnose such diseases and give appropriate treatment to patients. Midodrine, which is an alpha adrenergic agonist, is a vasoconstrictor and an oral therapy that is used in cirrhotic patients, which significantly improve various clinical outcomes, reduces the need synthesis and associated risk, as well as improves patient comfort. It is also recommended by American Association for the Study of Liver Diseases guidelines. To discuss the potential role of midodrine in patients with cirrhosis, I would like to invite our speaker to the webinar, one of the eminent doctor from Ahmedabad, Dr. Pathik Parikh. Dr. Parikh is a consultant gastroenterologist, endoscopist, liver transplant physicians at Apollo Hospitals, Ahmedabad. He has 15 plus years of experience with special interest in acute liver failure, non-alcoholic fatty liver disease, and portal hypertension. He's also trained in the field of transplant hepatology, immunology, nationally and internationally. On his name, Fellowship in Hepatology from London, Fellowship in Liver Transplant and Liver Intensive Care in London, Fellowship in Liver Radiology and Oncology from Japan. He has 50 plus publications in the index medical journals. He has also written a book which is Essentials of Liver Transplant, an Indian Perspective, which was published in the year 2021. He has also written 10 plus chapters monograph on liver diseases and transplant. He has presented 25 plus presentations at various national and international. He is the respected member of esteemed medical associations such as Liver Transplant Society of India, American Association for the Study of Liver Disease, Indian National Association for the Study of Liver, European Association for the Study of Liver. If you see the awards and recognitions, this is, he is gold medalist. He has received gold. He stood first in DM Gastroenterology in the year 2014. He has also received Young Investigator Award in the year 2015. The next award is the Liver Care Foundation Scholarship for Doctors in the year 2015, Dr. P. N. Berry Scholarship for the Study Abroad in 2015 and GN Tata Scholarship for the Study Abroad in the year 2015. He has also received INAZL GSH International Fellowship for Young Hepatologists in the year 2019. With this, I would like to hand over the session to Dr. Parikh. I welcome you all once again. Thank you for joining us this evening. Over to you, sir. Thank you.
Thank you for your introduction. I'll just share my presentation.
Okay, sir.
So what I am talking is about how to use Midodrine in patients of cirrhosis in a right manner. So before going on to the Midodrine, let's start with the scratch basics that, we divide cirrhosis into compensated cirrhosis, decompensated cirrhosis, and stage liver disease. And when we talk about the complications of cirrhosis, it is broadly be classified as those due to portal hypertension and those due to liver cell failure. Now, it is quite evident that there is no role for Midodrine in patients who develop liver cell failure. And for portal hypertension, the major role is for ascites. So as we all know, most of our patients come to us with ascites. It's the most common cause of referral for liver transplant. And those who develop cirrhosis, there is very high likelihood that they are going to die over the next 2 years. So the guidelines are very clear that anybody who develops cirrhosis, they should be at the very onset be started with salt restriction and diuretics as per all the guidelines. And they should be told about the need for liver transplant in future. As we have seen that, most of the patients with cirrhosis and ascites die within 2 years. And that's why liver transplant should be counseled to those patients when they develop ascites for the first time, that they would need it in near future. So coming to where Midodrine fits into between these two, about starting diuretics to the transplant, is where we would be talking today. So what happens in cirrhosis is there is increased intrahepatic resistance, which is dynamic as well as structural changes. This leads to portal hypertension, leading to splenic vasodilatation. And as a result of splenic vasodilatation, there is hyperdynamic circulation. Now, splenic vasodilatation can be attributed to increased vasodilators as well as decreased response to vasoconstrictors. So to simplify it, we need to understand this basic concept. When there is increased sinusoidal pressure, there is peripheral vasodilatation and effective hypovolemia. Ineffective hypovolemia leads to increased plasma renin and sympathetic nervous system stimulation. This leads to water retention, sodium retention, and renal vasoconstriction. This leads to refractory ascites, hyponatremia, and hepatorenal syndrome, previously known as HRS, now as AKI-HRS. And that's where we would be talking about the role of Midodrine. Also, once the sympathetic nervous system is activated and renin-angiotensin system is activated, the kidneys and the heart get involved as well. And the most important part about the development of AKI and HRS is the involvement of heart, that is increase in cardiac output. So this is a wonderful slide which says that as the cirrhosis progresses, as the HVPG is gradually increasing in size, increasing in number, there is initially increased compensation of splenic arterial vasodilatation by increasing cardiac output. But there comes a point of time where cardiac output can no further increase, but there is significant splenic arterial vasodilatation. And as soon as a stressor comes in, instead of further increasing, the cardiac output decreases. And once the cardiac output decreases, the organ perfusion decreases, and that leads to refractory ascites and other complications. And one of the important prognostic factors in patient of cirrhosis with ascites is the mean arterial pressure. So if you look at the mean arterial pressure, if it is more than 80, the median survival is 46 months. But as soon as the mean arterial pressure falls below 80, the median survival falls to less than 1 year. And same applies to AKI and hyponatremia, which we are already aware. But this is the importance of blood pressure. And as we all know, as the disease progresses, the more development of refractory ascites, hyponatremia, and HRS, the outcomes are very poor without transplant. So what we have concluded as of now is that, circulatory dysfunction is a key pathogenic factor in complication of cirrhosis. So if we can improve the circulatory function, it may delay or prevent the further progression of complications of cirrhosis. So how do we do it? Can we really work on it? So let's go about the stepwise process on how the portal hypertension works. So for portal hypertension, we have beta blocker. For splanchnic vasodilatation, we have vasoconstrictor. For raised heart rate and cardiac output, we have beta blockade with vasoconstrictors. Systemic vasodilatation, we have vasoconstrictor. Low preload, ineffective volume, albumin. Low GFR, volume plus vasoconstrictors, and increased volume, diuretics and aquaretics. So this is how we can treat the underlying pathophysiology of development of complications of cirrhosis and portal hypertension. And if we can see the role of vasoconstrictors, which we are going to talk, is splanchnic vasodilatation, increased heart rate, systemic vasodilatation, as well as low GFR, which is counteracted by vasoconstrictors. So when we talk about vasoconstrictor, I think midodrine is an orally available alpha-1 agonist, which increases the systemic and splanchnic blood pressure and increases the effective circulatory blood volume and renal perfusion. So what's the clinical implication of understanding all those pathophysiology? It can be used in cirrhosis with ascites, refractory ascites, EKI, PICD, hyponatremia, and hepatic hydrothorax. So we would be quoting studies about all these uses. So let's talk about the cirrhosis with ascites and one of the earliest studies in 1998. So in 1998, Paolo Angeli used 15 milligrams per day midodrine in patients of cirrhosis with ascites, and he found out that over a 3-hour period, there was significant increase in the blood pressure, as well as there was decrease in the heart rate. Also, there was improvement in the renal blood flow, as well as improvement in the GFR. The plasma renin activity decreased and the ADH level decreased significantly after patients were given midodrine, and that is immediately within 6 hours it was studied. Now, this group, Greek group, also studied the effect of midodrine for 7 days. So in patients without cirrhosis. So if the patient has just cirrhosis and there is no ascites and you give midodrine, what happens? So even in those patients, it was at day 7 able to increase the blood pressure significantly, decrease the heart rate significantly, improve the decrease the cardiac output, and improve the SVR in patients without ascites. But when he gave in patients with ascites for 7 days the midodrine, besides the same changes, there was improvement in the renal blood flow, as well as urinary sodium excretion was improved. Also the plasma renin and the aldosterone improved in patients with ascites. So when midodrine is given in patient of cirrhosis without ascites, there is no renal benefit. But when it is given in cirrhosis with ascites, there is renal benefit documented. Again, a study which looked at 3 days combination of octreotide and midodrine in patients of cirrhosis and ascites. There was significant improvement in plasma renin activity, as well as GFR levels in the patients when given midodrine octreotide for 3 days. A systemic and meta-analysis was carried out and which favored the use of midodrine in patients of cirrhosis with ascites. So in cirrhosis with ascites, it does improve the underlying pathophysiology of patients in renin activity and aldosterone, as well as improve the renal blood flow. Now coming to the major use, which is the diuretic refractory and intractable ascites. So I think we do not know it to go into the definition of resistant ascites and intractable ascites, but both qualify as refractory ascites. So when the Indian group carried out a study in patients with refractory ascites, they assessed the response at 6 months as compared to standard medical therapy. And if you look at the midodrine group, at 1 month, the partial response was there in 83% of the cases. And at 3 months, nearly 90% of the patients had some complete or partial response in this patient, which persisted at 6 months. So in the patients of midodrine, the complete or partial response was seen in more than 50% of the patient, and which persisted over a period of 6 months. But if you look at the individual data, the mean arterial pressure, this is the main reason why we are giving it. So at 1 month, the MAP was significantly better in the midodrine group as compared to the standard medical therapy. And the cardiac output was significantly better in at 3 months, and SVR improved at 3 months. So although the MAP increases by 1 month, the definite systemic effects are seen at 1 to 3 months. But if you look at the mean pressure at 6 months, that is lost. So the advantage of midodrine was lost at 6 months in the mean arterial pressure. If you look at the renin activity and aldosterone, obviously, as expected, the midodrine group had significant lower levels of renin activity. And the survival turned out to be better in the study on the midodrine group with refractory ascites. So midodrine improves outcome in patients of refractory ascites. So what if we combine midodrine with other agents? So midodrine has been tried combining with other agents as well. So midodrine and tolvaptan. So in patients with cirrhosis and ascites, at 1 month, only the midodrine plus tolvaptan group had a complete response. But if at 3 months, midodrine alone as well as midodrine plus tolvaptan had a complete response in patients with ascites. So in patients with cirrhosis and ascites and refractory ascites, so midodrine with tolvaptan also had a response. So midodrine has been combined with clonidine. Both have an effect on this portal hypertension as well as systemic circulation, and clonidine being an alpha-2 agonist was attempted, and it improved the response to ascites as well. Midodrine has been combined with rifaximin as well. Now rifaximin prevents the gut translocation, a belief that it decreases the gut translocation, so the PAMS and the DAMS decreases, and as a result, the portal splanchnic vasodilatation decreases. So when we combine midodrine with rifaximin, can it improve the survival as well as the improvement in the ascites or not? So this was studied, and they found out that over a period of time, the complete response was quite significant in the combination group as compared to a single agent. They also found that there was survival benefit in those patients who responded to the combination of rifaximin and midodrine. Now, this is just recently published data that if there is a patient with diuretic who are getting some side effects or having a recurrent ascites, they are put on weekly albumin therapy to achieve a target of 4 gram per DL, which is very high, I believe, and combination of midodrine. So if you look at the doses of midodrine, it is 12.5 plus minus 2.5. So 10 to 15 milligram thrice a day. So the higher normal doses of midodrine, so up to starting from 30 to 45 milligrams of midodrine per day was given in this patient. And what they found out was this patients had a better response as compared to the standard medical therapy. And this is just recently published by the SGPGI group this year. So cirrhosis without ascites, it just improves the MAP, no renal improvement. Cirrhosis with ascites, it improves the renal blood flow. Cirrhosis with refractory ascites, it has definite benefit. And in cirrhosis with refractory ascites, in combination with agents like clonidine, rifaximin, and tolvaptan, it does improve the renal function much better, and the MAP and the portal hypertension much better. Now coming to the next group of patients is patients with acute kidney injury. I do not go into the definition of acute kidney injury. We all know how to define acute kidney injury: stage 1, stage 2, stage 3. And the standard of treatment for HRS is terlipressin. So Pathik and group compared the midodrine octreotide group with terlipressin in these patients. And where they found out that as expected, terlipressin fared better throughout the treatment course as compared to midodrine octreotide, and those who responded to terlipressin had a survival advantage than those who responded with midodrine octreotide. So terlipressin in the patients of AKI amounting to HRS, terlipressin has shown superiority over midodrine octreotide combination. And again, a recently published study where terlipressin was compared to hepatorenal syndrome, AKI, and they found out that it fed much better overall survival as well as transplant-free survival as compared to midodrine group. So terlipressin in patients of AKIs is superior for as compared to midodrine. So in this network meta-analysis, what they found out that for reversal of AKI HRS, terlipressin plus albumin or noradrenaline with albumin were the most preferred agents. The only place where midodrine fared better to terlipressin was the serum sodium. So we all know that terlipressin causes hyponatremia. So in change in serum sodium, octreotide plus midodrine fared better in the patients of AKI as compared to terlipressin. Now, we all know that terlipressin has effect on multiple places, while midodrine would be effective in systemic vasoconstrictor as renal perfusion. While if you look at the terlipressin effect, it is widespread, and so the terlipressin is expected to behave superiorly as compared to midodrine in patients of AKI with HRS. Now coming to the next group of patients, this development of paracentesis induced circulatory dysfunction. Now we all know that PICD is a entity where patients develop low blood pressure and then AKI and hyponatremia after paracentesis. So this recent data showed that there is a significant fall in systemic blood pressure as well as diastolic blood pressure after paracentesis, and which is not corrected even after 24 hours to 48 hours. So the effect of paracentesis persists for 48 hours, and we need to deal with this and prevent PICD. So this study looked at midodrine 12.5 milligrams every 8 hourly. So again, this is very high dose. We need to see the dose for 3 days as compared to albumin, which we give 8 gram per liter of acidic fluid removed. So when they compared between the midodrine group and the albumin group, the midodrine group and the albumin group, the MAP obviously was expected to be higher in the midodrine group as compared to the albumin group. The fall was much significant for albumin group. In another study where they have compared 3 groups of albumin group, short midodrine group, and a long-term midodrine group. So after paracentesis, should we continue midodrine for 2 days or should we continue for 30 days? And they looked at the effects. So if you look at the renal impairment in the 2 groups, obviously those who continued the midodrine had better outcomes at a short term, as well as if they look at the long term, the difference between albumin and midodrine in renal impairment did not last very long. But there is definite short-term advantage of midodrine over albumin in patients after paracentesis. Hyponatremia, again, it was seen in at 30 days in albumin 17%, while 13% in patients of on midodrine. So those study, again, they looked at another study, they looked at renal resistant artery index and urinary sodium excretion, and as expected, midodrine served to have better response in those patients. If you look at the meta-analysis, from this, obviously it favors the combination of midodrine and albumin in the patients as compared to a standard medical therapy. Now, there is some data of use of midodrine in ACLF patients as well. So this again study from India, from AIG, they looked at if oral midodrine can prevent PICD in ACLF patients. So most of the patients that come to us are actually ACLF. And we have seen that in ACLF, none of those drugs work. But here in ACLF, they have not tapped a dry tap. What they did was they tap up to 3 to 5 liters of fluid. So when they tap 3 to 5 liters of fluid, they compared the role of midodrine and used the midodrine for 3 days. And when they used midodrine for 3 days, obviously the PRA as well as the mean arterial pressure was much better in the midodrine group. So they said that if you are tapping up to 3 to 5 liters and you are using 3 days of midodrine, then the effect of paracentesis is cut down and curtailed, and we can have better hemodynamic parameters after paracentesis in ACL of patients as well. Minded, it is not for large volume paracentesis. For large volume paracentesis, you still need albumin. Now there is some data to suggest its role in patients of hyponatremia as well. We ourselves carried out a pilot study in 10 patients previous long back, and it showed improvement in hyponatremia as well with midodrine. Now, this is a wonderful study from AIG where they have shown whether patients who are on diuretics, we are worried that diuretics would cause them side effects. So can midodrine curtail the side effects of patients on diuretics? And again, the dose used was 22.5 milligrams per day. So time taken to control ascites was significantly shorter in obviously midodrine group. Less number of taps were required in the midodrine group. Low volume of ascites was removed in the standard through group as compared to the treatment group. So patients were developing more complications in the standard group. If they looked at the hemodynamics parameters at 1 month, the midodrine significantly increased the MAP without change in the heart rate. There was significant increase in the urinary sodium, but the mortality benefit was not evident. Midodrine addition in early stage of acute portal hypertension improves the hemodynamics, tolerability of diuretics, and ascites control, and it is safe and effective in ACLF patients. That was the conclusion. So in ACLF patients also, it can improve the tolerability of diuretics, and it can be added in midodrine, added to diuretics. So coming to the patients who are awaiting liver transplant, this was the study which was criticized by Indian group a lot of times, but where they compare the long-term use of midodrine in patients who are awaiting liver transplant. And they said that midodrine and albumin was not superior to placebo, and there was no survival benefit and or the risk of developing complication. And what they found out was that although the MAP was improved initially, but the overall in a few weeks, the change disappeared. The advantage of midodrine disappeared. However, the noradrenaline and the aldosterone level, so renin-angiotensin system was definitely suppressed in the patient on midodrine as compared to the standard medical therapy. The Indian group criticized this study, saying that though it was low dose of midodrine used, that was 15 milligram, but if they could have used 22.5 or more, the response would have been much better and the outcome would have been better. Now, again, they have tried using midodrine in patients in the ICU. So we have a patient in the ICU who's on terlipressin, and we want to liberate the patient from inotropes by adding midodrine. And there is another trial which is going on, which is known as Liberate trial. The result would be out soon, but the current MIDAS study showed that adding midodrine in patients in ICU to taper off inotropes earlier was not effective. There have been some studies for hepatic hydrothorax as well for use of midodrine and terlipressin and vasopressors. Now coming to the side effects, there is a warning written that it can cause elevation of supine blood pressure, and it should be told to the patient. There is case reports of midodrine associated bradycardia, Takotsubo cardiomyopathy after midodrine, and severe myoclonus associated with oral midodrine who have been documented that we should all be aware of. So if patients develop some of the side effects, we should be stopping midodrine. Coming to the guidelines, where the guidelines say about midodrine, I think oral midodrine has been shown to improve clinical outcomes and survival in patients with refractory ascites. Its use should be considered in this setting as per the American guidelines. But for hepatorenal syndrome, they say that albumin plus infusion of vasoactive drugs such as octreotide and midodrine should be considered as a class 2 evidence. The recently published guidelines in 2021, they say that in patient of HRS, if Turley and NORAD are not available, then oral midodrine can be used in this patient. But if you look at the dose, it is 5 to 15 milligrams every 8 hourly should be used in combination with octreotide. So not 2.5 TDS. We have seen patients being tried with 2.5 TDS, but it has the minimum dose is 15 milligrams per day minimum, and an ideal dose would be 22.5 milligram 3 times per day in a 3 divided doses. Even the EASL guidelines say the same thing, that in HRS, we can give midodrine if terlipressin is not available. The PASL guideline, if you look at, midodrine may be used in patients with refractory ascites and may be beneficial, especially in patients with low MAP. And midodrine should be started at 5 milligram 3 times a day. So the starting dose is 3 times a day, 5 milligrams, and titrated according to the rise in vein arterial pressure. Even the Japanese guidelines say that octreotide, midodrine, and albumin infusion improves the survival of patients with type 1 and type 2 HRS. So we should not forget that the standard treatment regime is salt restriction, nutritional counseling, and diuretics as tolerated. And then to add midodrine, this is my policy that if the MAPs are high, above 85, I don't add midodrine. But if the MAP is between 75 to 85, I add midodrine 15 milligrams per day for all patients to improve the diuretic tolerability. And if the MAP is less than 75, the dose would be at least 22.5 to up to 30 milligrams per day. So to conclude, we believe that midodrine should be started early rather than late in the ICU. So once the patient develops AKI and ends up in an ICU, or develops septic shock or some form of shock and patient ends up on inotropes, midodrine is not very effective. But if midodrine is started early in patients of ascites, refractory ascites, before they develop AKI, and they improve the diuretic responsiveness. But the responsiveness of midodrine is not indefinite. So either this patient should be transplanted in 3 to 6 months of time, or the predisposition to the decompensant should be taken off, and the patient should develop improvement in liver function so that they don't require any long-term midodrine. So midodrine for a short-term effect up to 3 to 6 months, it is definitely useful in patients with refractory ascites. So I conclude my talk. I've written a book on essentials of liver transplant. If somebody needs a copy of it, it's a handbook for all gastroenterologists. Feel free to contact me. Thank you. And I'll be happy to take questions now.
Thank you, sir. Thank you for the wonderful talk, and it was very informative with the practical usage of midodrine in critically ill patients who are having or awaiting liver transplant. We can start with the Q&A session, sir. The first question is regarding what are the parameters or the vitals which we need to monitor on regular basis while patient is on midodrine?
I think midodrine increases the blood pressure. So it is treated for postural hypertension. So we need to measure the supine blood pressure. He should not develop supine hypertension. And because the patients that we are talking about is cirrhotic patients with ascites, definitely. So they need to undergo the standard monitorings of heart rate, weight, pulse, sodium, potassium, urine output, as well as overall responsiveness about the clinical effects. But I think we need to monitor for bradycardia. That is important.
Okay. Okay. And the next question is, when patient is on midodrine, what if the urine output has been reduced and how to manage?
So if the patient, midodrine is not a diuretic. So if the midodrine you are using as a diuretic and expecting the urine to increase, it's not likely to happen. So midodrine just raises the renal blood flow and the urine increases and the patient is adequately filled. So if the patient's IVC is full, then you need to give diuretics. If the IVC is not full or collapsing, then you need to improve the albumin by giving albumin or even crystalloids to improve the renal blood flow. So midodrine per se does not improve the urine output. Midodrine improves the renal blood flow. But if the vessels are empty, you need to fill up the vessels. And if the vessels are full, then you need to add on the diuretic.
Okay. Okay. We have received one question that midodrine is sympathomimetic drug used in orthostatic hypotension, hemodialysis-induced hypotension, and more commonly for the treatment of HRS. Should we test the ascites fluid or cytology, amylase brain, natriuretic peptide, and adenosine deaminase?
Yes, so we should see it is irrespective of Midodrine. Anybody with ascites. So all guidelines say that new onset ascites in a cirrhotic patient, it should be tested. So the standard guidelines also say that it has to be tested. Role of fludrocortisone in ascites. I think fludrocortisone is a sodium retainer, so it is not to be given from any benefit of combining fludrocortisone, midodrine, and ivabradine.
Okay.
Uh, so, so the thought process is good, but overall, the role of ivabradine in cirrhosis, I am not aware whether how much it is going to benefit, because midodrine also causes bradycardia, ivabradine also causes bradycardia. So it has a synergistic effect. Whether it is causing a side effect or not, I'm not aware. But there is no data to say. I will go through it, and if there is anything, I'll get back.
Okay. Okay. So, um,
Yeah, so
what
midodrine
is
effect is not long lasting. So what
okay?
the question that is asked is the effect is only for short term. Urinary sodium excretion was only for short term. That is what my message is. That
Hmm.
midodrine is not a molecule which is to be continued lifelong and expecting it to continue to respond for the rest of their life. Midodrine's response in all studies have shown that it is short term, and beyond few months the response goes away. So either the underlying etiology should be taken care of or the patient should be transplanted, because the median survival of a patient with refractory ascites is 6 months. So if the effect of midodrine is lasting 3 to 6 months, I think it is doing its job uh, of giving a good quality of life by improving the decreasing the admissions and improving the urine output, along with the diuretics, including the diuretic tolerability. But it would not avoid a transplantation, which is mandatory.
Okay. How to combine midodrine with clonidine, as both the drugs have opposing effect on blood pressure? That is the question which we have received.
Yeah, so one of the major side effects of using clonidine, and that's the major reason why people are not using, is developing of hypotension. So the clonidine is expected to work on the splanchnic vasodilatation and affecting the splanchnic blood flow, and midodrine also affecting the systemic. But because of the effect of clonidine on the systemic circulation, there is more development of hypotension, and as a result, those who develop hypotension after clonidine should not be used. A
Okay.
significant rebound in renin-angiotensin.
Yes. How to manage refractory ascites in the presence of associated comorbidity and hypertension? That is the question.
So if the say midodrine's role comes in when there is hypotension. So if the patient is already having a blood pressure systolic of 160 and a diastolic of 190, I don't think that midodrine is to be given in those patients. Midodrine is unlikely to act on it. It may complicate. So as I said, no, MAP above 80 is should be the target. But if already you have a MAP above 90 and 100, then midodrine is not going to be effective. It is going to cause more side effects. So midodrine, in most of our refractory ascites patients have a low MAP, and that's when midodrine comes into the picture.
Okay. So many gastros feedback is like there are different dosage of midodrine. They use 2.5 mg thrice daily. In some cases, they are using 7.5 mg thrice daily, and cardiologists use 10 mg. So, how to differentiate and what will be the correct or the ideal preferred usage of
I
midodrine?
think we stick to the APASL guidelines. No, we start with 5 milligram twice daily, 15
Okay.
milligram in the patients when we start, and we look at the map. And if the map is coming up with 5 milligram TDS, we don't go up. But if the map is not coming up at a week, we need to go up on the dose. And if you go through all the studies, the dose that up to 5 milligram TDS to they have used up to 15 milligram TDS. And nowadays 10 milligram TDS is the usual standard dose for those map, those having patients having map less than 70.
Okay. Can midodrine cause gaseous abdominal distension? Why is the last dose of midodrine should be given? What is the last dose of midodrine should be given to the patients?
Sorry, I didn't catch the question.
Can midodrine cause gaseous abdominal distension? What is the last dose of midodrine should be given? What is the maximum dose should be given to such patients?
So I think 45 milligrams is the dose which has been given, but for all, if those who don't respond to 30 milligrams per day, I doubt they are going to respond to 45 milligrams per day. So up to the guidelines say 5 milligram TDS to 15 milligram TDS. So 45 is the maximum dose that needs to be given in this patient.
Okay. Can midodrine be combined with carvedilol or propranolol?
Yeah, that's the controversial question that has been often asked, that both are having exactly opposite effect, and can that be combined?
Hmm.
And there are no data to support or refute this thing, but a lot of patients with refractory ascites with hypotension, they are already off carvedilol. So we cannot give carvedilol in those patients. So only when we achieve a mid blood pressure or a systolic blood pressure above 120, 130 on midodrine, that is when the question comes about adding carvedilol. And in those patients with varices, and they do not develop, they do not lose the effect of midodrine, we would consider adding carvedilol for portal hypertension, added benefit on portal pressure. And if you look at one of the slide of pathophysiology on the splanchnic vasodilatation, beta blocker as well as vasoconstrictor, both were shown to benefit in this patient. So theoretically, yes, you can combine, but practically adding beta blocker to a patients on midodrine who are having hypotension is less likely, because we would not come across those patients.
Okay, okay. So what is your take on regarding the supine hypertension with the usage of midodrine?
I think supine hypertension is something which is being mentioned as a warning in these patients of midodrine, and that's why we need to monitor the patient. So a lot of times patients coming to the clinic are being monitored in a sitting position only, and we keep on increasing the dose, but we need to make sure that those patients who are on at least 22.5 or more than 15 milligrams per day of midodrine, we should be evaluating supine hypertension or blood pressure as well to look for supine hypertension.
Okay. The next question is patients with autoimmune diseases already have low blood pressure. So what should be the diagnosis in such patients?
So anybody with cirrhosis overall, as a period of time, the disease progresses, may not be autoimmune. It may be even ethanol or steatotic liver disease related patients. They all have low blood pressures. And midodrine, it does not affect the etiology of liver disease. Midodrine just affects, it does not affect the liver per se. It affects the systemic vasoconstriction. It increases the SVR. So the purpose of etiology is not important in this.
Okay. Is midodrine helpful in CLD with CKD?
So most nephrologists are now using midodrine regularly, and they use at 30 milligrams per day. So because all those patients of CKD who are undergoing hemodialysis, they tend to develop hypotension during the dialysis episode, and that's why the nephrologists use midodrine in those patients.
Okay, okay. Comparison between noradrenaline versus terlipressin and midodrine.
So I have already presented in my study that for AKI, but obviously in a walking, talking outpatient, you won't be using NORAD or terlipressin, so it is midodrine only. But when we talk come about, the patient is in the ICU and the patient has acute kidney injury or are already on inotropes, then midodrine doesn't have any role. It doesn't decrease the rate of inotropic tapering off. So terlipressin and NORAD in patients of AKI and in ICU. Midodrine not to be used in those cases.
Okay, okay. Midodrine alone is effective or is useful more in combination with albumin?
So all our studies have been done on AKI with albumin and midodrine. For this recently study where they have seen albumin on a weekly basis and midodrine in the Indian study from AIG, adding, so see, what it finally boils down to is treating the underlying pathophysiology. So by giving albumin, you are tackling ineffective plasma volume by improving the volume, so that the volume increased is going to the renal circulation, and by compressing the systemic circulation by midodrine, you further improve the blood flow to the liver. So it has a synergistic effect in those patients.
Okay. Okay. So I guess we have finished with the questions.
Thank you.
So you can summarize the session. So
So I think to summarize, my message is only that Midodrine is only for selected patients with refractory ascites and ascites in an outpatient basis where patients are coming for TAP or before TAP or after TAP. We need to continue Midodrine at least for 3 days, and up to 30 days it has added benefit to prevent PICD. And the effect of Midodrine is not going to sustain for over years. So those who require Midodrine need to have an exit strategy of treating underlying etiology or transplant by 6 months. Otherwise, they are not going to respond to Midodrine at the end of 6 months. If the patient is in ICU, Midodrine is not going to be effective. So use Midodrine wisely in outpatient basis of patients with ascites and refractory ascites to help improve or increase the dose of diuretic and prevent the side effects. That is the message for Midodrine. Watch out for heart rate and watch out for supine hypertension in those patients.
okay, sir. Okay.
And the dose, yes, don't start with 2.5 milligram thrice daily. It is pseudo dose. So if we are starting with Midodrine, it has to be minimum 15 milligrams per day.
Okay. Okay. Thank you, sir. Over to you, Vikrant.
Thank you, Dr. Pathik Parikh. So, as we draw this enlightening webinar to a close, it is my privilege to extend our heartfelt gratitude to all those who have made this event a success. Firstly, sir, a huge thanks to our speaker, Dr. Pathik Parikh, one of the leading gastroenterologists and hepatologists of Ahmedabad, whose insightful presentation and thought-provoking discussions have enriched our understanding on Midodrine, its role, and the right approach. Thank you, Dr. Pathik Parikh, for this wonderful presentation. I would also like to express our deep appreciations to our participants for their gracious presence despite of their busy schedule, and thank you for your active participation and engaging questions. I would also like to thank our Senior Vice President, Sir, Mr. Nehru Dadi Sethi, sir, for his generous support and guidance for the webinar, and also like to express my deep gratitude to our entire sales team, including our sales heads, our medical advisor, Ms. Hetal Goyal, our IT team, and entire PMT team, especially Reena Yadav, for their exceptional efforts and attention to details. The entire scientific session was sponsored by Hetero Healthcare, the makers of MidoHep. As we conclude, we hope you leave with new insights and learning. Please feel free to reach out to us or our team members for any feedback or further questions. We would look forward to welcoming you to our future events. Thank you once again, Dr. Pathik Parikh and entire participants for their gracious presence and participations. Thank you.